Hi, I'm Joe Roth. At New Jersey Sharing Network, we're committed to saving and enhancing people's lives through organ and tissue donation and informing people about our life-saving mission. That's why we're proud to support programming produced by the Caucus Educational Corporation and their partners in public television.
Providing comfort during illness next on Caucus, New Jersey.
Funding for this edition of Caucus, New Jersey has been provided by the New Jersey Education Association, Wells Fargo, New Jersey Resources, Horizon Blue Cross Blue Shield of New Jersey, Berkeley College, New Jersey Sharing Network, dedicated to saving lives through organ and tissue donation, and by MagnaCare. Promotional support provided by NJ.com, Small News, Big News, True Jersey, and by Commerce Magazine.
Welcome to Caucus, New Jersey. I'm Steve Adubato. Palliative care can help improve the quality of life for those at any age. Here to help us understand the benefits of palliative care, we have Dawn Pavlu, who is a palliative care nurse practitioner, Dr. Richard Rosenbluth, Director of Palliative Care Medicine at Holy Name Medical Center, Karen Davidson, Chief Nursing Officer at CareOne, and finally, Debra Mazza, Palliative Care Counselor at University Hospital. I want to thank all of you for joining us to talk about palliative care. Doctor, right off the bat, I don't want to assume that people know what palliative care is. What is it, and how is it different from hospice care?
Palliative care is sometimes hard to define in a very, very short.
Well, just give me an example of it.
Well, the term palliative comes from the Greek term meaning to ease and to provide comfort. And the principal objective of palliative medicine is to provide comfort and symptom control for patients with chronic illnesses,
such as
often life and generally life-threatening illnesses. I think the types of patients we see are predominantly patients with advanced cancers, patients with neurologic diseases, dementia and degenerative neurologic diseases. But it includes patients with chronic renal disease, chronic kidney disease, liver disease, chronic respiratory disease, heart disease. Anybody with a chronic illness that is life-threatening and associated with complaints of discomfort of varying sorts. But that's really only one aspect of what I think is, there are three aspects to palliative medicine. That's the first, providing comfort and symptom control. Another thing that we do that I think is very important is very often patients with serious illnesses are bombarded by all sorts of different suggestions as to what they need to do. And some of these suggestions come from their physicians, of course.
Sure.
So what we try to do is, by getting to know patients and understand what their values are and what's important to them in life, we help them navigate among all these different options. Do I go the route of chemo? Do I go the route of radiation? Do I look just for supportive comfort measures?
You navigate.
Exactly, we navigate.
And what's the third part?
And the third part, which is a direct extension of that second part, is we help ease people into that phase that we call end-of-life care, when the chronic illness, as inevitably is the case, is no longer amenable to the usual medical treatments. The time has come to consider how we're going to function at the end of life.
Right.
And that includes, of course, hospice care as the major component of end-of-life care.
Is hospice a natural progression of palliative care?
I would think so. I mean, what we're doing in palliative care a lot of times is establishing what goals of care are. And obviously we're working with people who have life-threatening and life-limiting disease. So whether that's either a chronic or acute disease, such as a cancer, or a chronic disease such as heart failure, eventually everyone is going to come to the end of their lifespan. And it is very natural, if we've been involved early, to take them through their disease process and then all the way to the end and make sure that they are transitioned into a hospice setting where they can have the best quality of life for whatever time they have remaining.
You know, Deborah, as a counselor in the field, right? There's a bigger picture question I wonder about, then we'll get back into some of the details. Why is it so difficult for so many to even talk about and deal with these issues? And is it ultimately the fear of death?
Yes. I think that a big part of what I do is find out what matters most. What matters most to that patient. And then if there's a relationship established, then we can talk about what their fears are. And oftentimes they're afraid of dying, but a lot of times they're afraid of dying because they're afraid they're not going to be comfortable. So it's kind of the fear of the unknown. So we try to have conversations about what their fears are. Oftentimes it's that they're going to be in pain.
Do you help them understand that some of that pain, if not all of it, can be managed?
Yeah. Sometimes it's existential. Sometimes they need symptom relief because it's actual physical pain. But as a palliative care counselor, I try to look at the whole person.
How about the family? Are you dealing with them as well?
Big part of what we do. Big part of what we do. Because when patients are suffering, oftentimes a component of that is the worry for the family.
Talk about the team approach. Who's involved?
From the very beginning, I would say the doctor is probably the driver. In our setting, the doctor, the attending physician, definitely the nurses on the floor, chaplain, whatever religious, choices the patient makes, social work, dietitians, that's the team.
Why do you need all those players?
It's the patient's a whole. They make lots of choices.
You know, the whole question of palliative care, trying to ease, as you said, the pain, doctor. To what degree do you have to initiate that discussion? Do clinicians have to initiate the discussion of easing the pain, as opposed to patients saying, look, I want to talk about this, I want to understand this, so let's talk about it? Who's driving it?
Well, it's a very interesting point, because one of the problems that we've encountered in palliative medicine, I should mention palliative medicine is a relatively new specialty
Right.
in terms of medical specialties. One of the problems is getting both patients and physicians knowledgeable about the services that can be provided.
Yes.
Obviously, you would imagine as a patient, you would look to your physician,
That's
your
right.
primary care doctor, to help ease your symptoms as well as treat your disease. As medicine has become so super specialized,
That's right.
physicians don't have the time. It's not that they don't have the inclination. They do. Physicians are healers, and they really do want to take care of patients, but sometimes they just don't have the time. What we like to tell people is that we provide sort of an extra layer of care that does not compete with the care that the primary physician is providing or the specialist is providing, but we're making life easier for them.
And so I'll go back, doctor. Because there are so many different illnesses that we're talking about. See, because I'm thinking to myself, you could have a patient who's dealing with cancer, serious cancer, and at a certain stage, and then someone with dementia in a serious situation, and it's affected our family in a very direct way, and so I understand it. And so therefore, what I'm struggling with here is the patient with cancer who's aware and his mind is sharp, and you can have that conversation with, right? That's one case. But in the other case, you're not dealing with that patient about those issues. You're dealing with family members. It's a very different conversation, right?
Absolutely, absolutely. It's an important point. Very important.
So how important is healthcare proxy? Who's really involved? Who's responsible? And I'll come back to you, doctor.
Well, that's what I was going to speak to. So much of what we do is advanced care planning. And
Advanced care planning.
advanced care planning, let's talk about if we get to a place where there is no chance for a reasonable recovery, what are your wishes? And those conversations are so important to have very early on, because then when you have your family member that has dementia,
Yes.
if you had the conversation, then the family has no decision to make because they already know what their loved one would have wanted.
You know, I hear you.
And that's our problem, which you asked before, kind of our societal problem, is that we don't want to talk about death.
Yeah, I'm healthy right now. Now, you want to have a conversation with me about, okay, say I get this really, really tough break and I either have serious cancer or I have dementia and I'm in a tough situation. You want me to talk about that now?
Yes.
Really?
Yeah. And
I'm living life.
Right. And it doesn't have to be a morbid conversation either.
It doesn't.
It's part of your life. You know, in American society, you know, we have all these beauty creams so you don't have wrinkles, and we, you know, don't talk about death. We, you know, we kind of shun old age. You know, get a facelift, you'll look like you're 20 years
No,
old
but you're talking
again.
about two different things, aren't you? You're talking about the facelift and wanting to look younger and cosmetic surgery. Isn't that one thing? But now you jump into this whole other discussion about not wanting to have an honest, candid, timely, critical discussion about end-of-life care. Aren't they two different things?
Well, think
No, I
about,
think
think
it's a
about the way.
continuum.
You think it's all part of the same thing?
It's all the continuum. If we were more understanding and more accepting of the fact that we are mortal beings, and everyone who is born is going to die.
That's
and
a
what you
guarantee.
have-
Are we
that's
sure
a-
about that?
That's a guarantee, and we know that for sure, right?
It's not going
And
to change
so
anytime
There's
soon.
no deal you can make
There's
anywhere.
no
It's just
side
one
deal.
big-
Everybody wants to try and find the side deal, but there's no side deal. And to have that conversation is actually an act of compassion.
Right.
To have
Okay.
that conversation with your family members, saying, if I should get dementia, or even at the diagnosis of early stage dementia,
could still
when you
engage in
have
conversation.
when you have the cognitive ability to express yourself, to say, listen, when it gets to the point where I don't recognize anyone, where I am bedbound, where I'm no longer able to eat, I don't want you to put tubes in me. I don't want you to put me on a respirator. I don't want to live with a permanent tracheostomy.
This is a quality of life issue.
This is like a
Well,
quality
then what
of
is
life.
it that you say?
So,
You would realize how important what Dawn was saying really is if you ever sat in a family meeting where an advance directive does not exist, and you have 2, 3, 4 family members, children, the wife, and they're struggling. They don't really know what to do.
What goes on, doctor?
They just don't know what to do. Do I opt for an aggressive resuscitation attempt? Would my father really want to be on life-sustaining ventilator therapy for the next God only knows how long? When you see that kind of struggle in a family, you realize, exactly as Dawn said, what an act of compassion it is for a parent to say, I'm going to relieve you of that obligation because I'm going to tell you in a written document what it is I really want.
Is that part of palliative care?
That's an essential part of palliative care.
An essential part? Go
It
ahead.
is.
Oftentimes, I see the patients get comfortable with it quicker than the families. Because if you're the one with the illness, you're in tune with your body, you know what's happening to you for the most part. If you get a diagnosis of dementia, you know the path it's going to take. So the patients get more comfortable with it, at least what I see, sometimes than the families. It's hard for families.
It's a burden for families.
Talk about it.
Family meetings, sitting there and talking about artificial nutrition. For someone who we know the risks totally outweigh the benefits, but yet the family never had a conversation, so they don't know what to do. And now they're left thinking they feel sometimes that they have control over their loved one's life, when in fact they don't.
They don't.
But they feel like they do because that decision wasn't made and that conversation wasn't had. And oftentimes what we will do in family meetings is we'll say, okay, we know that your loved one can't participate, but let's imagine he was part of this meeting. What would he say? What would she say? And oftentimes families, sometimes they don't know.
And part of palliative care is helping families through those very difficult discussions.
Absolutely.
The family is an integral part of the units. You know, sometimes I think of the following, that palliative medicine developed as a specialty
About how long ago?
because, well, 10, 15 years ago.
Okay.
But it developed as a specialty because of the over-specialization of medicine. In the old days...
Why? Because people were kept alive longer?
Well, no, I wasn't even thinking in those terms. I'm thinking in terms of the old Marcus Welby doctors, the primary care physician of old, who probably because there wasn't that much that one could do for patients, spent a lot of time with them. They got to know their patients. They were an integral part of their patients' lives, often in small communities. And they provided the type of care that the super specialists are no longer providing. So I think palliative care is almost like a throwback to that early age. I often think of myself, my training has been as an oncologist for almost 40 years. And what I feel I'm doing now as a palliative care physician is so much closer to being a family doc and an old-time doc.
Really?
Because we're doing the sort of things that the old-time docs used to do, literally taking care of a patient. Not treating a patient, but taking care of a patient.
Do you know your patients better now?
We get to know them.
Do you know patients better?
Yes, and
Do-
I
go
get to
ahead,
see them sometimes on multiple visits. So, I work for the VA of New Jersey healthcare system, and what's nice is we get incorporate early palliative care. And so I get to see them through multiple visits. And so I get to establish that relationship. And so when it comes to making harder decisions further down the line, we already have a very trusting relationship.
Right.
We have that establishment, and it makes it a little bit easier. And one of the very nice things, as Doctor was saying, is that the shift now is almost back to palliative care, in that palliative care now is becoming part of the curriculum, I believe, for medical students. I know for advanced practice nurses, nurse practitioner training. One of my other functions is I'm an adjunct professor at NYU in the graduate program, and we do palliative care simulations with all of the specialties, the family nurse practitioners, the acute care nurse practitioners, the adult nurse practitioners, so that now this should be becoming part of everyone's base education.
Is it?
It's starting, yes. Which is what we want to be, because then what we should be doing as specialists, palliative care specialists, are coming in for those more specialized cases. But if palliative care is started earlier and incorporated by everyone, basic palliative care principles incorporated by everyone, every patient's quality of life is going to improve.
How pervasive is it? How pervasive is the concept and the practice of palliative care across the board in the medical community?
In my opinion, we have a long way to go on that. I think we've made advances, but it's still not a comfortable conversation. It's still
Even in the medical community?
No.
I think Dole made a very good point, and that is the early initiation of palliative medicine in a patient's illness. We've been talking about end-of-life care,
Yes.
to a large extent, but a critical component of palliative medicine is treating people who are not necessarily going to die. Let me give you some specifics. There was a study done that was published in the New England Journal of Medicine a few years ago, where patients who were newly diagnosed with advanced lung cancer were randomly assigned to two different groups. One group was given chemotherapy in the conventional fashion. The other group was given chemotherapy and simultaneous palliative care contact.
Right.
And what they expected to find, they did find, and that was that the quality of a patient's life definitely was better in the group.
Define the quality of life.
Well, by a variety of parameters. Are they patients in pain? Do they have other symptoms? Are they suffering? Do they have a positive attitude towards life? That definitely was better in the group that was treated. But what they didn't expect to find, and did find, was that survival was greater.
They live longer?
They actually lived longer.
You surprised by that?
No, but what I wanted to say was when we talked about what is quality of life, that's so individual. And that's part of what we do. We sit down and we find out what does quality mean to you? Because everybody's quality is different. Somebody wants longevity. Somebody may want to live until their granddaughter is born. We need to get that information up front.
Very personal?
Absolutely.
Yeah, but there are quality of life questionnaires that have been vetted and have been substantiated as valid. which includes a variety of different questions.
Well, being able
about
to get out and
quality of life.
walk and
Yeah, exactly.
and walk, take a walk
One's
in the park.
mobility and do people feel depressed? Are people able to sleep at night without too much difficulty? Are they fearful? Are they confident about the future? Are they at peace? There are all sorts of questions.
So let me ask you this in the limited time we have left. You know, we have our own issues, and let me just put it this way: what role can we in the media play in an effort to help people deal in a healthier, more realistic way about the fact that A, as you said before, there is no side deal to be cut, and you know there is an ultimate end for all of us, and B, that quality of life is critically important, and there is this movement called the palliative care movement, and there's something we can do about it. Can we help?
Well, I think something we probably neglected to say here, and the word is choice.
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 Meaning?
People need to know they have a choice.
Mean options.
And options. And so I think that's a big element in palliative care. And so to answer your question, if we just let people know that simple phrase, that they have a choice, and that we will discuss those choices with them. Because palliative care, part of what we do is allowing people to see their options. And again, it's all about what quality they're looking for.
Hold on, I want to be clear. Palliative care, are you in a hospital or are you at home?
Oh, that's an interesting point. That's why we have representatives here of CareOne, which is a skilled nursing facility.
Both.
What do you mean both?
You may start out at home, and at some point you may need to be in the hospital, and at some point you may need post-acute care like I represent. So you could be anywhere.
Ideally, palliative medicine should involve care in several locations. It's clearly of major importance in a hospital setting. But then as patients transition from a hospital to a skilled nursing facility, we need to provide it there. And we are doing it with the CareOne people. And then from there to hospice or to home. The ideal situation would be to have palliative medicine available to patients in every one of these locations.
Jump in.
Well, I was just going to say that most people right now, their first initial contact with palliative care is through a hospital, because we have, these acute episodes, and people come in, and then palliative care gets called in, and that's where most palliative care teams are now. But we are also expanding to the outpatient. There's also now legislation in New Jersey called the Palliative Care Information Act, which is still waiting to kind of go through committee.
Which would do what?
It would require that anyone with serious illness who is either in an acute care hospital, a rehab facility, a nursing home, a rehab facility, any kind of facility, would require that facility to provide information about palliative care to those patients.
So there's a fair number of people right now who don't know.
Correct.
About palliative care being a choice or an option, as you said, Deborah, right?
Because most people still are, and you ask about the media, most people are still equating palliative care with hospice care. And
hospice care is end of life.
Very, very end of life. While that's a part of palliative care, it's a very small sliver. You get the most value from palliative care, again, starting at the time of diagnosis, and we work as an extra layer of care on top of what the specialists are doing, on top of what the regular general practitioners are doing, to provide that comfort, the quality of life, to do that guidance through that entire disease trajectory.
Last question, time we have left. Because all of you are in the field, because of all of you are around this a lot, and you help people, are you healthier about talking about the subject of death because of this?
Probably ad nauseum. It's just something
So you're good with this?
I'm good with it.
You're good with it?
Death is part of life.
So you're good with it?
Completely
You're
comfortable
good with it?
Absolutely.
We got to talk. So you're saying because you've been around it, because you understand it's the quality of life and it's just part of the cycle, you understand.
But it's always been this way.
Yeah, I know.
It's only in modern society that we think that we can be young forever and that we'll never die.
Right. And that, like, death is something that's wrong. Death is natural.
But it doesn't, okay, I'm not gonna, that's another subject, but it doesn't mean it, people can be sad about what is happening, but it doesn't mean that it shouldn't be planned for and quality of life can't happen, right?
Yes.
Final seconds.
Yes.
And some people are happy when we bring up the subject because so often everybody's avoiding the elephant in the room.
And relieved.
And relieved.
And relieved.
And relieve that, okay, well, we could talk about
Yes,
this.
Right.
yes,
We can
guess
talk
what?
about
I'm
it.
scared. Can you listen to me? I'm scared.
Can we talk? And can you
Yes,
listen?
Yes.
Good. Well, I'm glad we talked, and I'm glad that we talked about palliative care because I think, I'm hopeful we helped a lot of people. I know you, all of you did. Thank you very much.
The preceding program has been a production of the Caucus Educational Corporation, celebrating over 25 years of broadcast excellence, and 13 for WNET, NJTV, and WHYY. Funding for this edition of Caucus New Jersey has been provided by the New Jersey Education Association, Wells Fargo, New Jersey Resources, Horizon Blue Cross Blue Shield of New Jersey, Berkeley College, New Jersey Sharing Network, and by MagnaCare. Transportation provided by Airbrook Limousine, serving the metropolitan New York, New Jersey area. Caucus New Jersey has been produced in partnership with TriStar Studios.
Seeing science in action makes students realize they can learn.
What is that organelle called? Elizabeth.
With the right tools, it's easy to motivate students.
Students need to know science to succeed in the global economy.
That's why NJA established the Center for Teaching and Learning.
To give teachers the training to make science come alive and to keep New Jersey schools among the best in the nation.
That's why we are so proud
To teach in New Jersey's public schools.